Again, I've already mentioned the fact that wellness is really one of our foci, and therefore physical activity is something that I'm particularly interested in. We're also going to talk about weight management, but I do want to make the point that weight management has undergone a lot of rethinking how we approach this topic in the 30 years that I've been doing this research. And what I want to start with is a very interesting perspective on the preventable causes of death in US women, and make the point that we often talk about heart disease as being the #1 cause of death in women, and then all cancers as the #2, and we can work through the diseases and what you would get on your ICD-9 codes, but in fact, there's not that much that we can do about them except treat them. And what we'd rather do is prevent them, and to do that, you need to change behavior. And so behavior is really something that we wanted to focus on. And I will come back to high blood pressure in a moment, because it stands out as being the #1 preventable cause of death in women, but it's not really something you can just change. You have to do some behavioral change to change blood pressure. Smoking, obviously, we all know about that. But today we're going to really home in on the next two, and to make the point that if you put these two together, you would in fact have something that's comparable to high blood pressure, if not more. And so we're going to talk a bit about it today. And then I also want to make the point that I'm not going to spend much time on diet today, which I know is a very popular topic, and everybody really wants to know what they should eat. We have lots of changes in our research all the time about what you should eat, and so we'll try and address that. But what I do want to point out, the reason I've kind of blocked them together, is that when we talk about blood pressure really is something that all of these behavioral changes that appeared on the slide before really come into the management of blood pressure. And so that when you look at that particular issue, I will tell you the DASH diet is a very interesting diet. It is pretty much the messages that have continued to hold up over decades, which is low in saturated fat and cholesterol, high in vegetables and fruits, nuts, things like that we've heard about. And you can actually go to this site. We'll have all of these slides available to you on our website, so you can find all of the references. But what you actually see, that the group that have really talked about how do we prevent, evaluate, and treat blood pressure, they recognize that weight reduction was really one of the important pieces. I will point out that to get the 5 to 20 millimeters of mercury change, you have to lose 10 kilograms. That's 22 pounds. So that's a pretty horrific task. You can adopt the DASH diet, which is going to be fruits and vegetables and low fat. You can restrict salt. Physical activity is right up there. And this is the guidelines that we're going to be talking about today, 4 to 9 millimeters, and then moderate alcohol consumption, really keeping it to not more than 1 drink a day. All of these are really important preventable issues or behavioral changes that you can make to take care of your blood pressure. And actually the data suggests that that does just about as well as a lot of the medications, most of the medications, and it doesn't have the same kind of side effects. So that's one thing that I just wanted to mention in the way of prevention. Now, most of you are aware of body mass index. It's kind of the new metric that we use to determine where people fall in terms of underweight, normal weight, normal, I'll put quotes around it, what is normal, overweight, obesity, and then different classes. And what I really wanted to point out is that this is something where a lot of people feel rather embarrassed about their weight instead of feeling that they can do something positive about it. So it's not a very good message to keep harping on people that they need to be thinking about weight loss. And I do want to make a point that women are more fat than men. This is our normal biology. And we talk about essential fat. People are often not aware that we do need some fat. Obviously, we don't want too much fat. There's plenty of data saying that this is, a serious issue. But there is something called essential fat that's stored in your organs, your muscles, your nervous system. For premenopausal women, this fat is important for childbearing. For postmenopausal women, older women, we really have this new eating disorder on the upper end of our lifespan now. If you're not aware, many older people just stop eating. and they don't eat enough, they don't have enough reserve to actually make it through all of the challenges of aging. And so this is something where we're now homing in on what do we need to think about on the upper end, on the other end of the life course. I will make the point that certainly we have subcutaneous fat. There's a lot of hormonal reasons that we have different kind of fat. And so I just want to kind of allow people to think that fat is not completely bad. And in fact, there are times when we really, really do need more weight. And this is a big women's health problem, particularly young girls or pubertal girls when in the 13 to 15 year range. About 1% of the population actually has very severe eating disorders that we need to be aware of. We certainly are aware of these at the Stanford campus. As we move on into the next age group, we have bulimia nervosa, which affects about 3 to 5%. These are serious diseases, are serious issues. And I think some of the mental health folks will probably address that. I will point out that boys have them too, and we see more of them as time goes on. But this is one of the health issues that we have to acknowledge when we talk about weight management. We can't just talk about one end of the spectrum. We have to see that there's an optimal place. This is definitely not it. And to make the point that we come in all shapes and sizes. And one of the issues that I talk about in gender medicine is that we have these stereotypes. Somehow all women are supposed to be either very thin, ectomorphic, or they're supposed to have certain kind of curves. And it's kind of like not that, it's more and more accepted obviously to be mesomorphic, but this particular slide is showing you all these body types of elite Olympic athletes. And to let you see that we come in all shapes and sizes and body types. And what's really important is to kind of home in on what's the healthy weight for you within your body type, and not to try and look like some stereotype. And so this is one of the new messages that we're trying to come up with. Now obviously this greatest loser was someone who really wasn't able to even see what her body type was. Maybe she's even gone too far into the wrong direction. This is really a challenging issue to say. We don't know what optimal body type is. And this is something that some of us are really interested in body composition. We're looking at what's really the right kind of muscle, what's the strength and quality of that muscle, how does that relate to the overall picture. We have lots of data coming along saying that subcutaneous fat may actually be healthy, and that it's really only the intra-abdominal fat that's bad. And so we have a lot of new thinking about this that I think is going to be really important as we try and make our way through true weight management. Now, I've been doing this stuff for a long time. These are really old slides. Actually, Nancy Ellsworth, who's here, was part of this decades ago. But the point that I want to make in this slide, and I'm realizing you can't see all of the numbers, this was a study of premenopausal age women. It was probably one of the first large weight loss studies ever done in premenopausal women of this magnitude with 132 women. And we randomly assigned women to control a low-fat diet and a low-fat diet plus exercise. And the first thing that we saw, I'll tell you, we also had men. When men add exercise, they lose a lot of weight. When women add exercise, they don't lose a lot more weight. So we do have some real differences in how we store and mobilize and utilize our fat compared to men. But what you see in the middle bar, this was really focusing on the good cholesterol, HDL cholesterol, and the bad cholesterol, LDL cholesterol. And it made the point that a low-fat diet actually is not very good for your HDL cholesterol. That in order that basically a low-fat diet drives down the HDL just like it drives down the LDL, but if you add exercise, you can protect that outcome. And this was one of the first studies that really showed that we really need to do them both. We can't just do the diet to get the LDL down. We needed to do diet and exercise to get the best lipid profile. We then conducted a study of similar size and scope, actually 190 women, where we had 4 groups. These were postmenopausal women who we selected for having adverse lipids to begin with. So they had low HDL and high LDL from the outset. Again, we saw that diet is really valuable for losing weight. Adding exercise didn't make much difference. Exercise by itself, which is in yellow, isn't a very powerful way to lose weight. I think most of us have learned that lesson. But it was a little confusing what was going on with this low-fat diet in terms of the HDL. But with the LDL, it was absolutely clear that the combination in a person who needs to change their lipids, the combination of diet and exercise is really the important thing. So it was another piece to say, we can't just do diet, and maybe just exercise alone isn't as good either. We need to do them both. Now to move on, see if I can move on. I think most of you are very aware that we've been following an obesity epidemic in this country. So each decade, we have moved from having, in blue, we have people who are less than 10%, the light blue, 10 to 14% of the people in that state are obese, which in this case, we're focusing on a 5'4" person that's 30 pounds overweight. So that'll be a little shorter than many people in this room, but you can get what the sense of that is. Within 10 years, we had only one state left, Colorado, that still had that low of percent. And all the other states had moved up to 15 to 19% in the dark blue, or to 20 to 24% in the tan. And by 2010, everybody had gained even more, so that there were really very few states that had anybody who was, kind of, well, these are percentages. So this is a huge percent of people in the state. Now, I will make the point that these same data, you can go and see how did they exercise, and there's a question to just point out that 24% of people from each of these states, and you can go through the different states, and they correlate very nicely with a percent of fat, said that they hadn't done any activity in the last month. And so this is part of why we link these two things together. Now, I will just quickly say that we've changed the way we do this monitoring now, and so you kind of have to start over again from 2010 with new colors and a new metric, but you still see that no state had a prevalence of obesity less than 20% in the United States. In the next year, this changed, and the next year, it got even fatter. So within each year, we're able to see these changes in our prevalence of obesity in these states. So obviously, we need to do something. I will tell you that I've been looking for an updated version of our national guidelines for weight, and we don't have it because the message is still all the same as it was in 1998. This was a place where we really homed in on this problem. We started to recognize that obesity comes with a health burden. You have more heart disease. You have specific risk factors for heart disease, unfavorable lipids, hypertension, stroke, gallbladder disease, sleep apnea, respiratory problems. All of this was kind of demonstrated. And I can tell you that very shortly thereafter, people started having fights about, well, is it fitness or is it fatness? And we had lots of papers come out, mostly men, but this particular one was on women, and it was looking at all-cause mortality or death, and it made the very good point that both of these are bad. Being unfit at a normal weight is associated with higher mortality, and being unfit at a higher weight is associated with even more, but both of these are going up. And so it really is an interaction that we need to be thinking about. Now, we don't all come in the same shape and size again. We also don't all put our fat in the same way. Women actually come in at least two forms. The gynoid form, which is the female form where we talk about the curves, and the android form where we talk about something that looks more like a male. So these are the male and female patterns. And we know that women who, by their genetics, put fat in their intra-abdominal space, which is not subcutaneous, it's inside the abdominal cavity. The physiology of that is quite different. That fat is released into the portal system, which goes into your liver, which affects your lipids and your blood pressure and your inflammatory factors, whereas fat that's in the subcutaneous fat is hard to release. So the good thing is subcutaneous fat seems to be more positive. It's hard to get rid of that fat, But then the good news for the android pattern is exercise is really a very good way to get rid of the intra-abdominal fat. One reason that men can release fat more easily with exercise is that that is a very mobile kind of fat store. And so those women really would benefit from exercise. Now, the point that I really want to make on this slide is that profile, that pattern, is much less healthy than having the female pattern. So if you are a woman with this android pattern, you're at greater risk for heart disease, you're at greater risk for diabetes, you're at greater risk for adverse lipids and for certain cancers like breast cancer and endometrial cancer. So I do want to say that this same guideline came out with what's the message. And the first message is one that most people who are losing weight hardly ever do. And that is start with 10% of your baseline body weight and plan to lose that over 6 months. Slow weight loss. That's not the way most people do it. So most people are losing weight where they do these crash diets that they can't possibly sustain, and they have a lot of trouble with that. So you actually want to be only losing, if you're in the normal weight or just the first weight up, the first obesity category, you only want to be losing about 1 pound a week at the most. If you're much more overweight, then you start to talk about 1 to 2 pounds a week. People just don't do that. They want to lose 5 pounds right away and get really excited about it. It's really hard to keep that off. And so one message for weight is that you have to be patient with it. Now, the best way of being patient is to do it through exercise, because it takes forever to lose that weight with that alone. And so I will add exercise, and also I'll say a little bit about behavior as we move on. Okay, so the next thing I want to say is another area in women's health that we've become very aware of is that this obesity epidemic has some serious problems on the younger end of the spectrum now. We've been very aware that women who are carrying extra weight have much more adverse pregnancies, and the worst part of it is that their fetuses actually change their physiology in a way that they come out ready to gain weight much faster than if you had been a normal weight pregnant woman. And so there are new guidelines that came out, now they're already 5 years old, that basically said depending on what you came into the pregnancy with as your weight, we want to be talking about different amounts of weight that you would gain. And so that if you were an underweight person, then you would gain that 40 pounds that many women talk about. But if you're normal weight, we're talking 25 to 35 pounds. You have to have some weight there for the fetus and for the placenta and for all the blood fluids that are going to be part of the pregnancy. If you're overweight, you gain less. If you're obese, you gain even less. And now there's actually a big discussion about if women are really obese, should we actually even be talking about weight loss during pregnancy? So there's a lot of discussion and a lot of research going on in that area. On the other side of the area, I already mentioned, we've been doing these studies of postmenopausal women, and it's a little hard without a pointer. I'll point over here, and I'm sorry for those of you over there. But this is a study in which we followed women for 8 years. There was a diet intervention that all the women did lose weight. It wasn't actually the intention of that diet to lose weight, but they did. As soon as people pay attention to their diet, they lose weight. It doesn't really matter what the diet is. Once you start paying attention, people generally lose weight. And then they gain it, of course, over time. But what you see are very different patterns in women in their 50s, 60s, and 70s, where so much of our focus has been on the women in their 30s and 40s, and we really haven't paid very much attention to women in their 70s and 80s. What you actually see in this is that women in their 70s are losing weight without trying, and when we actually put them into a situation where we can find out is it fat or is it lean, we see that they're losing a disproportionate amount of lean weight and they're gaining a disproportionate amount of fat weight, but they're losing so much lean that they still are losing total weight. And so we need to have a lot more focus now on the upper end of what is the optimal weight issue when we start to talk about women in their 70s and 80s and 90s, of which most of us are now expected to be. The other one that I wanted to point out on this study, and this was a huge study, so we had 49,000 women in this study. 20,000 women were in the intervention group, where the weight loss, and then the group that's just gaining weight over time for the most part in the 50s, and not so much in the 60s, no weight gain. Weight loss in the 70s in the control group. Those are the controls. The other one on here is showing you the situation if you start this study, normal weight, so this BMI less than 25, you actually are pretty likely going to gain weight over the next 8 years. If you start the study, so that's the 25, if you start the study a little bit overweight, you kind of go up a little bit and then you kind of hover, so you really come out kind of where you started. And if you are obese, if anything, you might lose weight. So our focus really needs to be on normal weight women in terms of preventing weight gain, unhealthy weight gain over time. The other group are really doing quite well at not gaining more weight. So the point being that we really are coming to new understanding about this whole issue of weight management. And I will tell you that the American Cancer Society puts out recommendations for nutrition that highlight their first 2 points are achieve and maintain a healthy weight throughout life, be as lean as possible without being underweight, avoid excess weight gain at all ages, and for those of you who are overweight and obese, losing even a little amount. And so the stress that I want to make is a little amount. Don't think 40-pound goals. Go back to the 10% over 6 months and be patient. The other one that is pointed out here is a physically active lifestyle is the important prevention message. And this is basically the lifestyle that we're going to move our way into now. I will point out that for children, we really recommend a lot more exercise for children, at least 1 hour each day, and engage in vigorous intensity 3 days a week. Limit sedentary behavior. This is a really important part of our messages. We've got to stop sitting so much. We've got you sitting here. We'll all get you up soon enough. But at any rate, we really need to stop being so sedentary, because that's a really important part of what we're doing. Now that brings me to the physical activity guidelines. And again, we have them out there for you, and they may be coming through, I'm not sure. But do grab those. We have a little kind of 2-pager on this. But this is something that was actually my colleague Bill Haskell at Stanford, William Haskell, played a pivotal role in pulling together all of these data from decades of research and working through what are the guidelines for the general public. And what was recognized in this big search through the literature is that there's pretty good evidence that physical activity can reduce our risk of early death, coronary heart disease, stroke, this adverse lipid profile, the HDL, LDL, triglyceride problems, high blood pressure, type 2 diabetes, colon and breast cancer in particular, and it can help prevent weight gain. It might help weight loss, but you really have to add the diet. It may prevent falls in older adults, may maintain cognitive function, and it seems to reduce depression. Now, in that regard, how do you do it? What are the goals for you? So volume is the key. It's not just one thing. It's a combination. The frequency, how many times a week do you do it? The intensity, what's the effort that you put into those bouts? And we talk about these things called METs, metabolic equivalents. That's really a hard thing to do, but the good news is there are these catalogs, and actually on that site that I've given you, you can go in there. They have whole records of how many calories do you burn with this activity. I bet that many of you in this room are really good at calorie counting of food, but how many of you really know how many calories you're burning as you sit here versus stand, as you move and walk versus run? And this is something that we really need to get that onto our radar screen, is how many calories can I use up? Because then maybe I could afford to eat that cookie. But that 100-calorie cookie is a mile of walking. So do you want to do the mile of walking? Sure. And then I can have my cookie. But you can't think the other way. So we've really got to get that going. I'm going to talk about absolute intensity and relative in a moment, but the third component of volume is duration, the time for each of these episodes. So volume is really the most important message, not just one of those things. When we talk about absolute intensity, this is basically activity is categorized by light, moderate, and vigorous. There are these tables now where you can actually find out, how much do I really get when I'm on my golf cart, getting out of my golf cart and doing the swing versus walking the whole course. And you can start to think about, how do I get, okay, maybe I could just walk to that next one, this today, and tomorrow maybe I'll walk to 2 of them. Just work your way through small steps. But you can basically look this up and just to see, leisure walking is light intensity, brisk walking is moderate, and then of course going all out would be vigorous. The other side, since I do a lot of work with older women, is really recognizing the importance of relative intensity. What's easy for me may be really hard for you. What's really easy for you may be really hard for me. And it's going to be a different amount of work that I'm going to have to expend to do that. So basically, sitting is 0, and highest is 10, and moderate is 5 to 6, and vigorous is 7 to 8. And the key thing is the talk test. So the talk test is basically, that will help you pay attention to your heart rate and your breathing. If you can talk without pausing, that's good, but you can't sing. If you're singing, then you're too light. So stop and sing, that's a great thing to do, but if you're trying to exercise at a moderate pace, you can't be singing. On the other side, vigorous, you can't even talk, so you probably don't want to get to that point too often, but a mixture works great. And then again, this point about fitness, we actually did this really interesting study in our Women's Health Initiative group where we had them wear accelerometers and these special oxygen consumption devices where you could actually see what's their oxygen consumption. And we had them do 7 minutes of washing dishes, 7 minutes of mopping the floor, 7 minutes of folding laundry, 7 minutes of putting a jigsaw puzzle together, and 7 minutes on a treadmill to see what was really happening. And what we learned was they were working very hard at levels that we would consider moderate intensity. And so something to recognize is that the older we get, the more vigorous this very same kind of activity will be. So basically, the messages for below 65 is avoid inactivity, medium amounts of aerobic activity, muscle strengthening activity, and I can tell you that for 65 plus, it's all the same messages if you can do it. But I will point out that 150 minutes of moderate activity, so the brisk walking, is equivalent to 75 minutes of the vigorous activity. If you're older, 75 minutes of moderate of walking, the same pace as younger people, might be your vigorous activity. So those are the important things. And then the last message on this is to say the recommendation is that you do at least 10-minute bouts. So in your small step, just think, what could I do 10 minutes more of today? And then I'm going to try and do 10 more minutes of that activity. Just do 10 more minutes of something. And that will be a good goal. And then you can just start adding 10 minutes as you please. I will say for muscle strengthening, I'm stuck, there we go. This is highly recommended. We don't have very good research on it yet. We're trying to find out, will this prevent this muscle loss with aging that we are so worried about? And so this is where we're doing more work, but it is a recommended thing. And the last thing I'll say on this before I tell you about our new study is that when we talk about weight control, we really have taken that out of this messaging because it's really hard to say. How much exercise does any individual in this room need to do for weight control? We use the same message that we're going to see obesity as a chronic disease, and therefore more is better, as much as you can do. And we're not going to specify the amount, but basically say that this is the way to go, or that just doing a bit more is going to help you. Now, I want to kind of make a quick transition to the question that we are about to ask here at Stanford. So what you should know is that we just got this huge grant to look at physical activity in older women. And it started with this observation in the Women's Health Initiative that if we took sedentary women as our relative risk group, and we looked at women who did just a little bit more, and even more, and even more, we saw that just going from being really sedentary to a little bit more reduced your risk of cardiovascular disease by about 33%, about 20 to 30%. and that if you were really, really vigorous activity, you would reduce it by 53%. And so this was an important observation. We had lots of these data on men, but we didn't have too much on women. So this was really one of the first papers to look at that question. And we actually then kind of tore it apart and were able to show that because we had so many, this was such a big study, this was 74,000 women, we also had enough black women to be able to say, and it's true in African American women as well. And we then looked at by age group, and again, setting each one of these where the relative risk is the sedentary group, you see that in women in their 50s, it's even a stronger relationship, even a little bit of a dose relationship. Not quite as strong when we get into our 70s, but the point being that a little bit more exercise takes you across the board into a lower and lower risk for cardiovascular disease. And then the last thing that we did lots of other things, but the last one I'm going to show you is looking within body mass index, and again, setting the relative rate. So we're not seeing here that, yes, the obese woman has a much higher risk than the lean woman, but to make the point that within those categories, starting where you are, now these are observations, they're not actual evidence, but starting where you are, women who were more active did reduce their risk. And so one thing I say to women who are struggling with weight, and it's very disheartening, I've done lots of weight loss studies, I know it's really depressing. The key is exercise, you get benefit out of that, whether you lose the weight or not. And so I think that's the important message that I want to make on that one. And then I want to just make the point that this was also one of the first studies that actually showed that women who sat less did better, had less heart disease than women who sat a lot. So this was one of our early studies. Now I will say that there has been a really important trial already done in diabetes that has shown in both men and women that diet and exercise, weight loss, does reduce your risk of diabetes. So we do have good clinical trial evidence of that. We don't have trial evidence yet for breast cancer, but we hope we'll get that in our study. But we do know that in this particular study, in WHI, we had plenty of women who got breast cancer. We saw that about 40% of them increased their physical activity after they got the breast cancer, 25% decreased it. But those women who increased their physical activity after that diagnosis had a much better outcome. And so we do encourage women to prevent breast cancer, but also if you've had breast cancer. So now I'm just going to wish you through WISH. This is our new big study. So the Women's Health Initiative Strong and Healthy trial, the WISH trial, is looking at cardiovascular disease. This is going to be the first trial ever to find out whether physical activity can reduce cardiovascular disease. We're using the guidelines that I've been talking to you about. So we're going with the DHHS guidelines, and we're using a program that I want you to know about called Go for Life, and I'll tell you about that in a moment. We also are going to look at whether this will affect fractures and falls and other kinds of mortality. And just so you know, this trial is going to be done in 52,000 women. So this is a huge trial, and Stanford is leading the physical activity intervention. So you should all be able to hear about this in about 5 years. We're also looking at other issues that relate to cardiovascular disease, so peripheral artery disease, blood clots, vascularization, and kind of the kitchen sink, everything that we think physical activity could do. This is a trial. We're randomly assigning women to control or to physical activity. The Go for Life program is available to everyone in this room. You can actually go to this site and order it, and it will come to you free. So it's something that's available to all of our controls, but we're going to actually mail it to our women in the study. And it has these wonderful activities. There's a website. I highly encourage all of you to get these materials, which we're going to be providing. And what I want to kind of just introduce is this concept of behavioral change. The stages of change is something that's a really important behavioral message for weight, for diet, for smoking, for physical activity. It starts out where some people just really don't want to change. I'm pretty happy just sitting in my chair, just leave me alone. And what we want to do with those women is just start to work through the pros and the cons. And so that's something I'm going to ask every one of you to do when you leave today, just think about one behavior you want to change, and then lay out what are the pros of making that change. And if it was all pros, you would have done it by now. So what's the cons? Why aren't you doing it? And what kind of barriers are you going to overcome? And so then you're going to start contemplating and thinking about, maybe I will make that change. Hopefully you'll get ready and make the change, and then you'll change. So this is a concept. And I can tell you there's lots of data showing that it takes people a while to finally make that change. But once they do, as you start to develop some success with your change, it goes really easy after that. So you have to be patient with yourself, work on that for a little while, but eventually you have a chance. Now, the WISH trial, we've already started mailing. We've mailed to our first 5,000 women. We still have 16,000, let's see, 26,000 total, 21,000 to go. But we've sent them the message saying, just move a little more. 1 more minute. We didn't say 1 more minute per hour, per day, per year. Just 1 more minute. Just think small steps. What can you do? Do it and then feel good about having done it. So we've started this off to try and get people to start now, find a buddy, do the things you love to do. Think about, what do I like to do? Some women love dancing, some women love shopping, some women love going and watching the flowers. Think about what you like to do. Don't go into something that's just boring. And we are going to be sending them the book from the Go for Life, and they're going to get pedometers, which we think are really helpful. So getting a pedometer will let you see your steps, and they're going to get all kinds of newsletters and peer counseling. We're actually going to have the women who like exercising talking to the women who don't like exercising of their own age group. And the last thing we are asking about, what do you like to do? How much do you like to do it? We're tailoring our messages because everyone in this room has something they like, and there's other things you just don't want to do. So why would I tell you to do that? You can figure it out yourself, what you really like to do. And so this is Move a Little More. This is actually a fold-out insert that we're just mailing to them now. We're actually using an interactive voice response system, a telephone system that helps them, prompts them, plug in your pedometers, it calls them so that you get somebody there coaching you every day. And I'm going to end with this slide to say this is the flyer that we have created that really talks about this stages of change. So Jana is someone who just says, I really don't want to exercise. Will you just stop talking to me about this? But you know what? I'm willing to read your book. And I'm willing to think about it. And I'm willing to write out the pros and the cons. And then Marta basically says, I don't like exercise either, but I'm willing to get up out of my chair once an hour. And I'm willing to look into Silver Sneakers, which is a great program that the YMCAs have. Annette is already doing something, and I will recommend these walking sticks. It's a great way to not worry about balance. But she's doing something, and her goal is to talk to a friend about doing a little bit more, walking 1 more day. Barbara is already doing it. She's out there making everybody feel like, oh, I should be doing that. But her thing is that she's going to just try and keep it up, that's her goal. And if she falls off the wagon, once in a while she'll get back up. And then Dee is just kind of ending with a message I'd like to end with, which is make it joyful. Enjoy what you're doing. And that's the place, is that basically exercise can be something that's fun. It shouldn't be something that's torturous. If it's torturous, you're not doing the right activity. So I'm going to end with that, and we're going to close the doors, and so you can get up and walk around for a few minutes and get your blood moving. Thank you very much.